radiodiagnosis at our institute, and he will be talking on artificial intelligence in the evaluation of coronary artery lesions in Kawasaki disease. So apart from his other attributes, he has a very special qualification, and that is that he is pursuing a PhD in artificial intelligence from the Indian Institute of Technology at Delhi. In fact, he is about to complete it, and there are only 2 medical doctors in this country who are doing their PhDs from an IIT while continuing their medical practice, and it so happens that both of them are sitting in this hall. So one is Pankaj, the other is Dr. Amitabh Chattopadhyay, who is pursuing his PhD from IIT Kharagpur.
Very little about Kawasaki disease, but what I like to do here is to just try to see what all has been done in artificial intelligence in this particular area, and how we can go ahead and help these children with more algorithms and other protocols to minimize the radiation and optimize care. So I just did a systematic review to understand what are the knowledge gaps as far as the AI in Kawasaki disease is concerned. So this search strategy was completed a couple of days back, and the aim of the systematic review was to identify the studies that have explored diagnostic performance of artificial intelligence for detecting coronary artery abnormalities based on clinical echocardiography, CT/MR or catheter angiography using machine learning algorithms. So as you see, I extracted 650 PubMed papers, and after removing duplicates and screening by titles, found 65 papers, out of which I excluded 28 by abstracts, and finally reviewed 37 full-text publications. And in this talk, I'll be talking about some of the studies which I find are interesting and can help us understand the disease further. This was my search strategy, basically tailored at including all keywords related to Kawasaki disease and artificial intelligence. Unfortunately, I'm not going into the details of AI and machine learning just for the sake of time, and believe that the previous speakers would have talked about them. So this is a very latest study that was published, and the general trend for machine learning in Kawasaki disease, which I find, is to develop nomograms for prediction of coronary artery lesions. So this study did the same. And as we can see here, this was 677 patients, and they had 16 parameters on which they built the machine learning algorithm. And in the final nomogram, they included 5 parameters. Out of the total cohort, the coronary artery lesions were present in 205 patients. And we can see that the area under curve for prediction of aneurysm in the validation cohort was 0.844. I'll be talking about the limitation of these studies. There are a lot of limitations when it comes to the experimentation and other aspects. So I'll be summarizing them at the last of my presentation of these papers. This was a second paper, again a similar approach, a larger sample size, more parameters included. This split is all right, and there is 5-fold cross-validation. And what we see is that now these authors are reporting even higher performance for prediction of coronary artery lesions. Another study, a very recent study again the number has further increased. The prevalence of coronary artery lesions in this cohort was 12%. And what we see here is that even the parameters which they included, and these are ranging from the clinical to laboratory parameters, have also significantly increased. There are more than 50 parameters which they included. And they came up with a nomogram which comprises of several important clinical and treatment as well as biochemical parameters. And they show that the area under curve for prediction of coronary artery lesions is 0.703. So just to highlight, we have 3 studies published in 2025 almost similar methodology, but strikingly different performances. This study, to me, looks more realistic as far as its performance is concerned. But again, there are limitations which I'll be discussing later on. So in these studies, as we realized, there are no imaging parameters included. All of them are basically clinical and laboratory parameters. And this was the study in 2024 that actually talked of radiomics based on echocardiography. So radiomics is basically like genomics, metabolomics, similar to that, where we extract a lot of information from the imaging and then try to develop an algorithm based on that. So in this particular study, they developed a model based on 3 clinical parameters and 6 ultrasound radiomic parameters, which they call as ultrasomic parameters, not a very standard term, though, to my information. And then based on that, they developed a machine learning algorithm. The good thing was that this study had 2 validation sets, which means more explanation of the algorithms in 2 different populations. And what we see is that the area under curve is 0.84 in validation set 1 and 0.74 in the validation set 2. Another study which again aims to develop nomogram and includes several parameters. These are like 45 parameters. And we see that the baseline Z score, which is based on the coronary artery echocardiography, is also included in the development of this nomogram. And they also showed that the performance was comparable to previous studies in the validation cohort. I'll skip this study and go to this particular study, which is of interest to me. So in this particular study, they developed an algorithm for automated detection of the coronary artery aneurysms based on echocardiography. And this was basically a detection algorithm which is very popular, popularly known as YOLO algorithm. You will read that in many AI-related papers. And you can see that this algorithm basically helps to perform automated detection of the coronary artery aneurysms and can be useful when there is limited expertise for performing echocardiography in these small children. And they showed that the typical metric for detection is mean average precision, which is MAP. And this is a very high MAP. Anything which is more than 60 is considered acceptable. And as we see that in this study, they have shown the MAP is more than 0.6 for almost all the algorithms which they developed. This, again, is a study which is of interest to me and which basically develops a classification algorithm based on the entire echocardiography image. So the hypothesis there was that this was done during the COVID time. So the authors included patients who had presentation which was similar to Kawasaki disease, but the final diagnosis was KD in 138 and 65 pneumonia patients. And they believed that the detection of coronary artery lesions in these patients would actually help differentiate Kawasaki disease from the other illnesses when there is a significant clinical overlap. So what they did, they basically trained the classification algorithm over the entire ultrasound image and then using different classification algorithms. See, these are not very sophisticated, these are very old algorithms and they are using the entire image, which is again a significant limitation of the study. Despite that, they showed that the models were sensitive, though poorly specific for the differentiation of KD from the other pneumonic illnesses. So overall, there were 6,390 patients in this review, which I did, and we can see that the area under curve ranged from 0.65 to 0.9. Again, a very varied performance reported by different studies. The specificity and sensitivity were also very variable in these studies. This is just an overview of all the studies, but my summary of this evidence is that the clinical parameters do have a promise for identifying the coronary artery lesions in patients with Kawasaki disease. However, I believe that imaging is underutilized, and the major limitation of this work is that they are all based on mostly single-center studies. And as we see, there are a lot of different clinical parameters that have been included. So it's important that for any AI-related studies, the models are tested on multiple different patient populations so that we can really prove that these models are generalizable to a different population, which has not been done in any of the studies which I have reviewed. Also, as I reported, there were only 2 studies that were based on imaging, so I believe that there is a lot of promise for the use of imaging for performing many of the tasks which Dr. Manful were also talking about. We just sort of tried doing something related to the Kawasaki disease. So I got a data of 10 patients with CT coronary angiography. 5 of them were normal and 5 were abnormal. And we thought of making a fully automated pipeline for detection of coronary artery abnormalities, or to classify the coronary angiogram as normal or abnormal. So this pipeline would comprise of initial automated segmentation and followed by detection. So how I propose to do it was, there is already a trained model that is available, which is a public model, which is known as a total segmentator, a very popular segmentation model for coronary artery segmentation, and then the detection algorithm. So this is the total segmentator model which I took from the GitHub, and then using this model, I did not train it. So this is a pre-trained model. So this obviously requires fine-tuning. I have done it in a very short period of time. So, but you can see that even when I run this model in the inference mode, it is giving me automated segmentation to, I believe, to some accuracy. There are missing segments definitely in between, and this can be definitely optimized. This is another example where again the segmentation algorithm automatically segments the left anterior descending accurately. There is part of the left circumflex which is also segmented, but it misses the right coronary artery. This was another algorithm which I tried to improve the segmentation, and we can see that now even distal part of the coronary artery is also being segmented. This was the segmentation part of it. Then I developed an algorithm for the detection part. So how I proposed the detection part was to basically identify all those segments that were more than 1.5 times the normal coronary artery, but that we understand would lead to a lot of overdiagnosis. And the question was framed in a way that if I see an abnormality on all the 3 planes, I consider that as a true abnormality, and across all the series that are available to me. So as a result of which, you see there are a lot of potential aneurysms which the model has detected, but there is a confidence score which I developed. So anything which had a confidence score of more than 0.5, based on their registration across different series and multiplanar images, was labeled as a confirmed aneurysm. In fact, this was a patient who had 2 coronary artery aneurysms in the left anterior descending and left circumflex, which were accurately detected. This is very preliminary work, obviously, and there is a lot of optimization that is required. But this seems promising, and we aim to test it on a diverse patient population. I think more important would be to develop a similar pipeline for echocardiography images, because their interpretation can be even more challenging. We also wish to assess more coronary artery lesions, and during one of discussions with Professor Surjit Singh, he asked me whether we can also assess the natural history of coronary artery lesions based on AI. So I think we can do that, but we need a lot of training data and follow-up of patients. And I am also looking forward to developing a large vision language model which will help us automatically report the coronary artery abnormalities using large language models. Thank you very much.
So that adds another aspect to the imaging issues of Kawasaki disease. Dr. Pankaj's talk is now open for comments.
That brings me to the philosophy of customer care. So I'm quite happy that me and Carsten are working for maybe a decade, maybe more than with good understanding. So when we discuss, can we do that directly, and thoughts can we bring immediate data, which is promising. Something we promise you that if we don't have any data, the data belongs to you. And if you are ready to do that, please go ahead. We will all support you. And if the things are in clear, and the team is very, very happy that we got this important aspect, is it can bring a change to the other centers who are struggling to integrate CTCA as a part of their management algorithm. Thank you so much, Pankaj, for coming here and giving such a lot of talk. Thank you so much.
I think this is one aspect of imaging about which we are likely to hear more and more, and more so in Kawasaki disease. Okay, so thank you, Pankaj. So with this, we come to the last session. and this will be taken by Dr. Suda, and she will be talking on coronary artery thrombosis in Kawasaki disease, presentation, diagnosis, and management.
Thank you. I would like to present our experience of PCI in Kawasaki disease. There are two major problems in PCI region caused by KD. The target vessel is small, and the size of the guiding catheter suitable for the use of larger balloon or bar is also limited by the diameter of the femoral artery. The second is existence of giant aneurysm with localized stenosis. Relief of stenosis is not always improvement of prognosis in such patients. Intracoronary thrombolysis, ICT, and intravenous coronary thrombolysis, IVCT, were useful for small children. Revascularization for ACS had these three effects: reduction of myocardial ischemia, decrease of myocardial infarct size, and improvement of long-term prognosis. I present the cases. I will present the treatment an 8-year-old boy with bilateral giant aneurysms. He visited the emergency clinic because of chest pain. His electrocardiogram showed hyperacute T wave in V2 to V4. An emergency coronary angiogram showed complete occlusion of the left anterior descending artery. Intracoronary thrombolysis by tishplasminogen activator was performed for the left coronary artery 2 times, and the thrombus dissolved. The reflow of the LAD was detected and chest pain was disappeared. Coronary angiogram after 5 years after ICT revealed the patency of the LAD. He had had no symptom for 11 years after ICT. However, he had undergone bilateral CABG at 19 years old because of localized stenosis in RCA and LAD. Here we see an infant patient in detail. A 22-month-old boy, body weight 10 kg, had severe KD with IVIG resistance at the age of 4 months. Coronary angiogram at the age of 6 months indicated bilateral giant aneurysm. At 22 months, he suddenly became pale and had syncope while walking morning. He was evaluated at the hospital 5 hours after the episode. Abnormal Q waves were present in his electrocardiogram. He was admitted to the hospital in the afternoon, and next morning he became pale again and hypertension. ST depression in his ECG was found. ICT was performed, but his condition worsened in the evening. and he was transferred to our hospital. Coronary angiogram at the age of 6 months indicated bilateral giant aneurysm. In the coronary angiogram, at the age of 19 months, the size of bilateral aneurysm decreased, comparing with the initial coronary angiogram. On admission, abnormal Q waves were present in lead 2-3 AVF of his ECG. Hypokinase of the inferior were detected on 2DE. These changes seem to be occlusion of the right coronary artery. In the next day, in second illness of the episode, STT depression in V1 to 6 was noted on ECG. It indicated ischemia of the left anterior descending artery. He was diagnosed as having acute myocardial infarction. Cardiomegaly and pulmonary edema were seen on chest X-ray. At the third illness, abnormal Q wave in V1 and V4. After intravenous coronary thrombolysis, coronary angiogram reveals segmental stenosis of the right coronary artery and severe stenosis of the left anterior descending artery. He was transferred to our hospital. He underwent coronary artery bypass grafting to the LAD with left internal thoracic artery 1 month after his acute infarction. Coronary angiogram 25 days after surgery indicated complete occlusion of the proximal portion of the LAD with distal LAD flow supplied by the internal thoracic artery graft. Although CABG improved perfusion of the anterior wall of the left ventricle, the BNP increased more than 1,000 picogram per milliliter. Again, and left ventricular endodiastolic pressure was elevated after surgery, suggesting a transient worsening of heart failure. Very low dose carvedilol was started. The LVEF improved. This slide shows the parameter of his cardiac function. Beta blocker and ACI were very useful for heart failure after myocardial infarction. This slide shows the finding of two-dimensional echocardiography. Mitral regurgitation was slight. In myocardial perfusion imaging, myocardial ischemia was improved after coronary artery bypass grafting. Thrombolytic agents are shown. Rapid diagnosis is very important. If CPK would be elevated, it's too late. Symptom and serial electrocardiogram should be checked, and two-dimensional echocardiogram checked. This 10-year-old girl had chest pain in the morning with ST depression. Although the chest pain disappeared after 1 year, she was transferred to our hospital. Thrombus in coronary aneurysm of the left coronary artery was detected by 2DE. A coronary angiogram showed an occluded left circumflex. Warfarin was added to the aspirin she was receiving. After 5 years, the left circumflex had reopened. In the same patient, CR's coronary angiogram are shown. The next is an adult case. The cause of acute coronary syndrome caused by atherosclerosis in adult is plaque rupture. In contrast, acute myocardial infarction in Kawasaki disease is caused by coronary artery occlusion due to thrombus. A 33-year-old female visited the emergency clinic because of chest pain and back pain. She was felt pain on effort before 3 days. She had coronary risk factor of obesity and smoking. The STT segment was elevated in lead 2-3 AVF in her 12-lead electrocardiogram. An emergency coronary angiogram showed 90% stenosis due to massive thrombus in an aneurysm of the right coronary artery. Aspiration of massive thrombus was considered too risky in those days. Therefore, intra-aortic balloon pumping was instituted. Chest pain was improved. After 3 days, thrombus size was reduced and stenosis decreased to 75%. Warfarin and aspirin were begun. She was discharged. However, she had further chest pain 30 days after initial attack. The ECG shows small negative T wave in lead 3. An emergency coronary angiogram showed complete occlusion of the RCA due to massive thrombus. The distal RCA was injected through from the left coronary artery. Repeated aspiration of the thrombus and percutaneous balloon angioplasty was successful. CPK was not increased. Early revascularization after acute myocardial infarction minimized infarct area. Pathological finding of aspiration sample was shown. The factor of plaque was none. She had no symptom and previous finding of ischemia. Thrombus suddenly developed in the large aneurysm many years after the onset of KD. After that, she has had no cardiac event for 15 years by treatment warfarin and aspirin. A 26-year-old man had acute myocardial infarction because of occlusion of the left main trunk. ST elevation in ECG was found. Percutaneous transluminal coronary thrombolysis using tissue plasminogen activator was successful. CAG. CAG are shown. He had a history of regression of both coronary giant aneurysm. He had been a smoker. Although he had no other risk factor, atherosclerosis. On the other hand, some stent malposition for ACS were reported because of underestimation of stenosis diameter on the morphological characteristic. It is difficult to evaluate the precise diameter of culprit region because of mass thrombus. If the patient is younger, it may be better to avoid emergency stent implantation, except in life-threatening situations requiring rescue. The previous study involved analysis of 62 patients who had had previous myocardial infarction. We reviewed 62 patients. The age at initial MI ranged from 3 months to 33 years with a median of 2 years. The distribution of the interval from the onset of acute KD to initial myocardial infarction is shown. The median was 7 after acute KD. Symptoms and signs at initial MI are shown. Chest pain, abdominal pain, and vomiting, pale, arrest, abnormal ECG, thrombus by 2DE, convulsion, and syncope were found. Time of MI is shown. Repeated MI was found in 21%. Area of MI is shown. Inferior MI and anteroseptal MI were 56% and 39% respectively. Thrombolytic reperfusion therapy is performed in about 50%. ICT and IVCT were 20 patients and 18 patients respectively. ICT and IVCT were useful in the smaller children. Thrombolytic reperfusion therapy should be performed rapidly. In the next, we reviewed the clinical feature of 50 adult patients who had ACS caused by CAR due to KD or probable KD from 1980 to 2008. Their age at the onset of disease are shown. 90% of patients were less than 40 years. 40% of patients had no coronary risk factor. Smoking was the most prominent additional risk factor. The left pie graph shows number of branches with CAR. The right pie graph shows the number of culprit regions. The initial treatment, the characteristics of culprit region are shown. Giant aneurysms were found in 42 patients. Calcification was detected in about 50% of patients. The initial treatment of ACS is shown. ICT and PCI were performed in 11 patients and 8 patients, respectively. 26 patients were treated medically. Elective CABG was performed in 15 patients. Outcome is shown in this slide. 3 patients died. ACS treatment has improved remarkably over the last 3 decades, thanks to thrombolytic therapy and improved PCI. Thank you for attention.
Enormous amount of data that she has presented, and years and years of experience, long-term follow-up of what happens to these children. And this is the kind of data which we don't have in India yet.
Thank you, ma'am. Besides having, academic things, what we need to learn is about how to love your subject, your persistence, perseverance, and long-term follow-up. Thank you, ma'am, for your insights. It definitely gives us so much motivation and definitely gives us momentum and impetus to work on this effect for environment. Probably in the decades to come, probably we'll have at least some kind of data like this that we can help to the KD community worldwide. Thank you, sir.
So what she has touched upon is the interface between pediatric cardiology and adult cardiology. So something I think which we need to involve our adult cardiology colleagues also, because many of these patients would be reaching them. So unless they are aware of Kawasaki disease and its complications, they would perhaps not be in a position to manage them adequately. Sorry. Devdatta, Dr. Amitabh.
What? It's an enormous data collection, I would say. One of the reasons, I can guess that probably they have been extremely meticulous in observing and maintaining the data. So far, in Calcutta, we had 3. And out of them, we have been collecting and maintaining somewhat to some, but not to the extent what she has done. I think it may be the proper one if an all India basis registry is maintained, so that we can at least get hold of what is being done and what is to be done, what needs to be done if we get such patients. Obviously, one of the main factors is what she presented on the long term. All the 3 patients had presented suddenly, even though they have been on some follow-up and on medications. So that is one of the critical junctures that the emergency aid and emergency medication and therapy can be given only when we are aware that this patient can present at this time or in this state at somewhat in his or her life. And they have to be told that this can happen despite all the things, preventable things, whatever we take. Because all the 3 patients presented almost in emergency condition, like stenosis, and they collapsed in some state. But they were quickly recovered and sent to the hospital, and the medications and other therapy were done.
Have you ever encountered a myocardial infarction in the acute stage?
So we have encountered in 2 patients, sir. One was a 5-year-old small girl who had familial hypercholesterolemia. Her father died at the age of 43 because of severe coronary diseases, and she presented with very overt entheism. He had giant xanthelasmas all over the body, including the knees and the ankles and everywhere. And she has eye features also. She went to CABG. But these people usually, even after the correction in the CABGs, they tend to reaccumulate the new grafts also get clogged down because of the inherent metabolic defect. So they have to put on high medications and they might have to undergo plasmapheresis. One was this one. The other lady was 11 years. She underwent CABG because that also was familial hypercholesterolemia and she was doing well.
No, in KD.
No, sir. In KD, we haven't had an acute one.
Any experience of acute MI in a Kawasaki disease patient? We haven't ever diagnosed acute MI.
So we haven't got an acute one. The child which we presented, in the 3 cases, they were semi-acute. They were presented as dilate cardiomyopathy. That means the damage has already occurred and they had survived it and presented later as DCM, dilate cardiomyopathy. We haven't had an acute attack.
perspective, I think the case that I presented the one with the RC stenosis, that child was actually having an acute MI. The one we lost to particular, the proponents were high. It was a 7-month-old child, very sick, and that child was to take of the retrospect. The child, before we could do anything, the child sort of crashed in the case with some potential ideas that he had. And just to include that when we are following up these children with KP, especially when they are having aneurysms and they are at risk, then I think we should include in every follow-up or make them aware that whenever these children, especially the small infants who are not vocal about their problems, when they are having these episodes of excessive crying, very sick, then we should include an ECG and enzyme tests in them along with the physical evaluation as well.
On the other side, the data is what was yesterday, 15,000 KD patients per year in Japan, 5 lakh children on follow-up. Lot of awareness is available, word is awareness. That once you do catheter angiogram in this cohort of patients, if you find anything which is suspicious of Kawasaki disease catheter angiogram, you go to the adult cardiologist, don't never think of that. You make aware of them. When I was in Yale University, I used to see helicopter flying every 15-20 minutes. This is the state of healthcare system in Japan. On the radiology basis, I tell you, in India, the population of MRI per 100,000 population is 0.2. Japan is 34. And so is the other CT scan. So this is, this matchless medical services that this country has spent on their citizens.
Sir, one of my colleagues, Dr. Snehal Patel, he had actually presented a case in Frankfurt. He had actually presented a case. He had a KD patient, 3 years, who presented with aneurysm and then clot. That was an emergency. And what he did was in thrombosuction. We have the pictures as well. He did a thrombosuction. He went inside the right coronary artery, took out the clots, and demonstrated after 1 year, he did a scan again, and the child was doing extremely well. RC stenting and thrombosuction. We have the pictures and we can show them. That was the only case I know of that he did.
What were the presenting complaints of this child?
The child, he had a KD and an aneurysm, and the child collapsed. And that was retrospective. And when they brought in the patient, he went inside and took out the clot with the right coronary artery catheter. He went inside the right coronary artery and took out that clot.
In a known case of KD?
Yes, sir, in a known case of KD, but they discovered it in a retrospect with an aneurysm and everything.
The parents were residing in Calcutta?
No, sir. He was from Gujarat, Surat. So that case, he had done an emergency thrombosuction. So they took out the clot going inside, and then they do that angioplasty.
They put a stent there.
Yes.
That's the problem.
That's the
problem. I had a long discussion with Professor Peter Mura, who is a pediatric surgeon, and I told him that we spent a lot of time and after lunch. He says in KD, you have to do intervention with lot of thinking. At that time, the operating cardiologist probably never thought that it's KD. There was bone aneurysm, there was thrombosis, he sucked it and then put them. We must understand the pathology of lesions of Kawasaki disease are entirely different to the atherosclerosis. My 18 years of cardiac radiology, I've never seen a single patient of atherosclerosis presenting with aneurysm. Presenting, if you put a stent, I don't know how effective it will be, that is time to tell. But as far as literature is concerned, you will not find a single patient like this who has been stented like this. I'm pretty sure about
I think they did under some emergency conditions. I got to the pictures.
That's fine. That's fine. I'm not saying to a particular case, because when you see something happening, you have to do something. That is a wonderful job probably done at that time, but for the sake of discussion, we are discussing this.
Sure.
Right.
What about its function as of now? Cardiac function.
Yes, yes.
No,
Yes.
no hypokalemia, nothing. That's great.
My question would be to all the cardiologists and other dignitaries here, like how do these children present with acute coronary syndrome? Because we have never seen anyone, and they don't complain with they don't come with the actual complaints, and there can be some risk cardiovascular disease also. So they may just present cardiorespiratory collapse. And in our center, and I think in most centers, they don't do ECG routinely in a child with cardiogenic shock.
So the thing I was saying that if I may, that's the thing I was saying that we should routinely improve that city and keep our minds open, especially when there is a history of occasion. With small infants who just present with excessive crying, sweating, they will not be able to tell the symptoms. And like adolescents with chest pain, the cases that Dr. Chotapata said, I don't know, that may have got different symptoms. But that one case that I saw, it just came in shock, a very, very cranky child with poor pulses, poor low BP, prolonged CRT, like any other features of cardiogenic shock. It was only the ECG when we documented the ECG, that also we should not see the ECG in the screen. It's very difficult to detect the STs, these segment changes if sudden. We should have an actual printout of the 12-lead ECG with the login. Along with the tropogens.
Especially in the issue of grading. Never forget to take ECG, and as she has told about the symptoms, crying, shaking, such occasions, that's more appropriate also. I sensitive appropriate. And another thing, in India, the organ donation has to be motivated, because very difficult to get pediatric hearts. Means pediatric heart transplant is very poor in India. Whereas in US, it's really happening. So here the parents should be motivated for in future, I mean, because all these PPCA, bypass and all is like a temporary measures only. So sometimes need a heart transplant also. I met one person who had 2 heart transplants with his child, he came to Taipei for 10 years.
Yes, Taipei.
So I was at Symposium. But in US it is happening, but in India, very difficult to get a pediatric heart transplant, because in tiny baby, bypass and all is very tough actually. Yeah, diffuse organ involvement someday. In future, we have to think about the heart transplant also.
Yeah.
So, couple of years back, we had a child around 2 years who actually had giant aneurysms, but was being managed by a very senior person, a pediatrician, with only aspirin. So this child was once admitted with vomiting. So in the afternoon, the child was admitted with vomiting, and at night we came to know that the child had collapsed. The child was immediately shifted to PICU. We realized that the child was having ventricular tachycardia fibrillation. They couldn't resuscitate it. Possibly it was acute MI.
A request to you or other esteemed faculty. See, when we diagnose a child with KD, just take a child with type 1 diabetes or CAH, we give a card to them. If these symptoms are there, anyone nearby should administer them glucose or something like that. So should we have some card for them? If some sudden collapse occurs, this should be suspected.
Yes, you have right. Brilliant idea. You can have that card parents tell their symptoms wherever they go. They should already.
Yes, I totally applaud this. We should.
All the gland evidence should be signed up. And even nowadays, the electrodes and they can monitor the ECG. So we can trace such operations. I thought that we will in my hospital to take the ECG and sucking the nurse. So
We are having a pediatric cardiologist over here. So is how is discussed in pediatric orthosis?
Yes. It's discussed definitely, and the section long term, but restriction that here, but it is discussed.
So I thank Dr. Suda. She has been tirelessly working over the last so many weeks for this. The kind of experience that she has, no one in the world has, and that is very obvious from her presentations. And I thank everyone in the hall for sitting here from 8 o'clock in the morning till 6:12. Thank you very much. So we meet tomorrow.